Hello, everyone. Welcome to the webinar on juvenile spondyloarthritis and juvenile psoriatic arthritis. This webinar is brought to you by CAPES, Clinician and Patient Education Series, a collaboration of the National Psoriasis Foundation, Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, also called GRAPPA, Spondyloarthritis Research and Treatment Network called SPARTAN, and Spondylitis Association of America called SAA, supported by an educational grant from Pfizer. Next slide, please. I'm Hema Srinivasalu, pediatric rheumatologist at Children's National Hospital at Washington, D.C., and associate professor of pediatrics at GW School of Medicine. I have the honor of moderating this session. I'm joined by an expert panel today. Here is our agenda. We'll begin with patient perspective by Wendy Olster, Asad Khan, and his mom, Amina Hamid. Wendy is a PhD student in Netherlands. She was diagnosed with psoriatic arthritis when she was 14 years old. She's on vacation and hence is not able to participate during the live Q&A, but we thank Wendy for her story. Asad Khan is a 16-year-old high school sophomore who lives in central New Jersey. Asad was diagnosed with ankylosing spondylitis when he was just 9 years old. Amina Hamid is Asad's mom. She's an educator and has been on this journey since Asad showed his first symptoms. We thank this patient panel to be part of this webinar today. Our clinicians include Dr. Dax Rumsey. He's the Zone Section Chief of Pediatric Rheumatology at Stollery Children's Hospital, Alberta, Canada. He's the Division Director of Pediatric Rheumatology and Associate Professor at University of Alberta, Canada. We are also joined by Dr. Pam Weiss, who's the Clinical Research Director at the Division of Rheumatology at Children's Hospital of Philadelphia, and Dr. Matt Stoll, who's the Associate Professor in Pediatric Rheumatology at University of Alabama at Birmingham. These, next slide, please. These are the planner disclosures. Next slide. These are the faculty disclosures. Next slide. This program is accredited for 1.5 AMA PRA Category 1 credits. We'll now proceed with pre-text test questions, followed by patient perspective and clinician presentations. Next slide. Question 1. Which of the following conditions is not typically considered to be in the juvenile spondyloarthritis family of related diseases? Answer choices are A, enthesitis-related arthritis, B, juvenile psoriatic arthritis, C, juvenile ankylosing spondylitis, D, chronic recurrent multifocal osteomyelitis, and E, systemic juvenile idiopathic arthritis. Please answer now. Okay, moving on to the next question. Question 2. Which of the following can be challenging to interpret on the pelvic MRI in skeletally immature patients? Choose all that apply. Answer choices: A, bone marrow edema, B, fat metaplasia, C, erosion, D, capsulitis. Please answer now. Question 3. Which of the following statements is correct? Answer choices: A, compared to adults, children are at higher risk of developing serious infections following exposure to TNF inhibitors. B, IL-17 inhibition with agents such as brodalumab or secukinumab is generally contraindicated in children with inflammatory bowel disease. C, baseline enthesitis is a predictor of improved functional outcomes in children with JIA. And D, children with ERA are more likely compared to children with other categories of JIA to enter remission following exposure to TNF inhibition. Please answer now. Now, without further ado, we will begin the patient perspective, juvenile diagnosis and treatment.
Hi, I'm Wendy Olster, a PhD student at the Eindhoven University of Technology in the Netherlands. I had my first symptoms when I was 14 years old and was diagnosed with juvenile psoriatic arthritis about 2 years later.
Hello, everyone. My name is Asad Khan. I'm a junior in high school and I live in New Jersey. I had symptoms around the age of 2 and was diagnosed with juvenile spondyloarthritis at the age of 9.
Hi, I'm Amina Hamid. I'm Asad's mom. I'm an educator and homeschooling mom of three. I have been by Asad's side since the beginning of his journey with ankylosing spondylitis and learning as I go through his experience with his symptoms, diagnosis, challenges thus far.
So Asad, you were diagnosed at a very young age. What was your disease history and diagnosis like?
Well, when I was around 2 years old, my mom noticed that I was limping when I walked. The limping would come and go. Around 4, I stopped walking suddenly due to pain in my knee. Doctors ended up finding fluid in my knee, so I was given a steroid injection to help calm things down. And then the pain had gone away until I was around 9 years old, and then it came back even stronger than before. We went to many specialists, but it took a very long time to figure out what was going on. And then finally, we went to a rheumatologist and we got tested. I was diagnosed with juvenile spondyloarthritis right after that.
It was certainly a challenging time not knowing what was causing Asad's symptoms since they started so early in life. Once he was diagnosed, we felt relief at least knowing what was going on for so long and could finally look into paths for treatment. So Wendy, how was your juvenile psoriatic arthritis finally recognized?
So for me, it also took a very long time to figure out what was going on. It started when I was 14 years old and I began having a lot of pain in my hips and my neck. I saw a pediatrician and multiple orthopedists, but none of them could really figure out what was going on. They even told me that I was too young to have a type of arthritis. And after more than 2 years of visiting hospitals, I finally visited a rheumatologist who could diagnose me with juvenile psoriatic arthritis, as the joint cartilage of my hip was broken down due to all the flares. For me, it was also a major relief, just like you, to finally get the confirmation of my diagnosis. So, how was your treatment journey like?
So after my diagnosis, I was put on an anti-TNF agent. I remember the first time we had to do the injection, it took over 40 minutes because we were just not ready and it felt very scary. So from making sure we were inserting the needle into my thigh correctly, injecting it, and then keeping the needle in my leg for 15 to 20 seconds so that all the medicine was in my leg. And then we would have to take the needle out. It felt like my leg was burning the entire time the needle was in my leg and the medication was going in. But after a while, I learned how to deal with the pain since I had to administer the injection every other week. And soon I switched over to a pen. And so we started using that instead of the injection, and it made a world of a difference to me. It's easier because I don't have to do any of the work, and it also definitely hurts a lot less. And I also had methotrexate added 2 years later as well.
Asad responded well to the medication, thankfully, and has been continuing with the same treatment. He's now able to keep up with his peers and play sports, etc.
I'm very happy you responded well to the medication. My treatment journey was a bit different as I tried a lot of different treatment options before I had the right one. I started with NSAIDs and steroid injections, but they only helped short term. I also tried a lot of different types of anti-TNF drugs, but I either developed antibodies or had a lot of side effects, and it took me years to try all these options. Luckily, I am now treated with an IL-17 inhibitor, which works great. So looking back at your experience, what would be the final message you would like to share?
So for people who are newly diagnosed, the disease and treatment may seem very daunting, but there are a number of medications that have helped many patients. And in my case, the treatment has been effective for the last 7 years. And I'm hopeful that with continued research in this field, there will be advancements, many more advancements, and one day a cure.
I agree. In the beginning, it feels like a lot, and it's important to know that you're not alone in what you're experiencing. It's always okay to ask for help, and we're lucky that although sometimes it can take a long time to find the right one, there are a lot of treatment options available. Thank you for allowing us to share our stories.
Hi there, my name is Dax Ramsey, and I'm a pediatric rheumatologist in Edmonton, Alberta, Canada. And today I'm going to talk about juvenile spondyloarthritis, clinical presentation, and classification. So in terms of the objectives for today, by the end of this session, I'm hoping that you as the learner will be able to recognize a patient who may be presenting with a form of juvenile spondyloarthritis, describe the main clinical features of JSpA, understand the current classification of JSpA, and recognize that this is an evolving area of pediatric rheumatology. So we'll start with the case. So this is the story of a 14-year-old young man named Edward R. Appleton, or ERA for short. This is a picture of him right there. So he presents to the clinic with lower back stiffness for the past 5 months, as well as bilateral heel pain. So just a note here in terms of pediatric patients. So children can be poor historians. They're not always able to describe their pain as well as adults. And sometimes they don't even complain of any symptoms. Also, the sacroiliac area can be called the hip by some of these patients. So you have to be really astute in your history taking. So in terms of history for Edward, just think about what you would ask this patient on history, what you would ask about in family history, and what kind of things would you look for on physical exam. All right, so getting into history, I would want to ask him about the onset and the duration of his symptoms in terms of the back pain and also the heel pain. Features of the back pain, like trying to get at whether it sounds inflammatory versus mechanical. So in terms of inflammatory, be more likely to be stiff in the morning, more likely to wake at night with the pain. And sometimes they get alternating buttocks pain. Versus mechanical pain would be more likely to be worse after physical activity and less likely stiff in the morning. Then I'd also ask about any preceding injuries or preceding illness, such as including gastrointestinal infection or GU infection. I'd also ask about some extra-articular features, such as eye symptoms, thinking of things like acute uveitis. So I'd ask about, is there any redness or pain or photophobia of the eyes? Any GI symptoms, any oral ulcers or any rashes, including like a psoriatic type rash? And also if there's any treatments he's tried, like medications or physiotherapy, chiropractor, any of those things, and the results, like did any of that help his symptoms? And then thinking of family history, I'd mostly be focusing on HLA-B27 related diseases. Was there anyone else in his family that he knew of that got diagnosed with a juvenile spondyloarthritis? Anyone with ankylosing spondylitis? Any family members with inflammatory bowel disease or IBD related arthritis? Anyone else that he knew of that had acute uveitis or the eye inflammation? Anyone with psoriasis or preferably physician diagnosed psoriasis or psoriatic arthritis? And any other autoimmune, autoinflammatory, or rheumatic diseases. In terms of the physical exam, I'd want to do a good general physical exam like in all patients, and also to check all of their joints. Certain things to focus on for this patient in particular. I'd want to do a good foot and ankle exam, and in the upper right hand or the upper left hand picture, this is kind of depicting arthritis of the left ankle and also enthesitis at the Achilles attachment. In the upper middle picture, this is showing the modified Schober test, which is looking at lumbar range of motion, which can be limited in these patients. And then the upper right is the Faber test, which stands for flexion, abduction, and external rotation. And this is a maneuver to stress the SI joint, and a positive test would be pain in the SI joint. Then something that you probably won't see on exam, but it would be a very good clue to the diagnosis would be some of these eye findings if they had an episode of acute uveitis. So redness of the eye, irregularly shaped pupil due to synechiae, which is when the iris adheres to the lens from the inflammation in the eye. And then this bottom picture here is showing some common sites of enthesitis around the patella and tibial tuberosity, the Achilles attachment, and the plantar fascia attachment on the bottom of the foot. And then this is just a table and a figure from our textbook of pediatric rheumatology showing a lot of the common sites of enthesitis, both in the upper and lower limbs. So just the clinical pearl. To check for enthesitis in terms of the amount of pressure that you should apply, you should ideally apply about 40 pounds per inch squared of thumb pressure or basically until, like, you push until the thumbnail blanches, which is a good pearl. So just moving into the next section on classification. Just a quick question. So what is the most likely rheumatic diagnosis that Edward has? Assuming that his back pain is from sacroiliitis and he has this heel pain, which is due to enthesitis. So do you think it's enthesitis-related arthritis, a thing called seronegative enthesopathy and arthropathy, or C syndrome, juvenile ankylosing spondylitis, juvenile spondyloarthritis, all of the above, none of the above, or too many acronyms? I'm out. So what do you think? So this kind of highlights an issue with our specialty in this area, that there's many different names for similar conditions. So first of all, there's a thing called ERA, or enthesitis-related arthritis, which is one of the categories of juvenile arthritis under the ILAR classification system, which is International League Against Rheumatism, and this is the most commonly used classification system. So to be classified as having ERA, a patient would have to have either arthritis and enthesitis, or arthritis or enthesitis and two or more of the following features. So those features would be sacroiliac joint tenderness and or inflammatory lumbosacral pain, presence of HLA-B27, onset of arthritis in an older boy, so a boy after the age of 6, a family history of one of those HLA-B27 associated diseases, and having acute symptomatic anterior uveitis. So more than 2 of those. Some of the exclusion criteria for this category would be if the patient or their first degree relative had psoriasis, if the patient had a positive rheumatoid factor in their blood test, if they presented with systemic arthritis, or if they had arthritis fulfilling 2 of the categories of juvenile arthritis. Next is a syndrome called C syndrome. And this is from a paper published back in the early 80s, so like in 1982, by Dr. Alan Rosenberg and Dr. Ross Petty, who are 2 classic pediatric rheumatologists in Canada. And this is called a syndrome of seronegative enthesopathy and arthropathy in children. And they basically described a lot of their patients that they had seen in Winnipeg and Vancouver, Canada. And they noticed that there's kind of a difference between some of these patients who had enthesitis and inflammatory back symptoms, as opposed to their other patients with juvenile arthritis. And they described this syndrome. And then I just kind of threw in another name. So this is Dr. Shirley C, and she's a juvenile spondyloarthritis expert in Canada. So maybe we should also call it C syndrome. Next, there's a title called juvenile ankylosing spondylitis, or juvenile axial spondyloarthritis. And this is basically a term used to describe those patients who fulfill the category for ankylosing spondylitis prior to their 16th birthday. And that's either radiographic or non-radiographic. So this, they could fulfill either the 1984 modified New York criteria or the newer ASAS criteria for axial SPA. Not a lot of our patients actually get back x-rays. They would more likely to get MRIs. So it'd be unlikely that they'd actually fulfill the 1984 criteria. But that would be like having clinical criteria and also radiologic criteria. And that's when you look at the x-rays and you'd see either unilateral severe sacroiliitis or bilateral moderate to severe. And then the ASAS criteria, they fulfill that if they have 3 or more months of back pain and age of onset less than 45 years, which would be all of our patients with the age category, or criterion rather. And then for this, they need sacroiliitis on imaging and 1 or more SPA feature, or they could be HLA-B27 positive and have 2 or more other SPA features. So there's a lot of terms. So the next term is called juvenile spondyloarthritis, and this is kind of an umbrella term. And this is usually thought of as including the ILAR criteria categories of ERA and psoriatic JIA and plus or minus undifferentiated JIA. So ERA we already talked about. Psoriatic juvenile arthritis, that's when you have arthritis and psoriasis, or you have arthritis and 2 out of the 3 of these other criterion, which are having a family history and a first degree relative of psoriasis, having dactylitis, which is basically like the sausage digit, or having nail changes, which include nail pitting or oncolysis. And the undifferentiated juvenile arthritis category is when a patient doesn't neatly fit into any of the other categories, or they get excluded because they fit more than one category. So, for example, if a patient was diagnosed with ERA, they met all those criteria, but they happen to have a family first-degree relative with psoriasis, then they'd automatically be excluded from the ERA classification category, and they would be called undifferentiated. So as you can see, the whole juvenile spondyloarthritis is not really well dealt with by ILAR, and there's a lot of patients that end up in this undifferentiated category. So there's actually a move to create a new classification system for juvenile arthritis, and that's being developed. So in terms of the epidemiology, among children with juvenile arthritis in general, about 10 to 20% have ERA. In terms of juvenile ankylosing spondylitis, where you have true axial disease, it's been found that about 1 to 7% of children with juvenile arthritis in several large national cohorts in the US, Canada, UK, and Europe have this axial disease. The age of onset is usually a bit older for the kids. It's usually on average about 13 years of age, as opposed to some of our other patients with juvenile arthritis that present a lot earlier on. ERA has a predominance of boys usually, so it's up to 9 to 1, boys to girls, depending on the country you look at. And then juvenile ankylosing spondylitis, or truly having the axial disease, has a male to female ratio of about 7 to 1. Having said this, though, it's likely underdiagnosed in girls, this condition. And some of the evidence for that is that HLA-B27 is very strongly associated with the disease, and it's found to be about equally prevalent in girls and boys. So that's the main presentation. If there's any questions, I'm happy to take any. Thanks.
Thank you to the organizers of this meeting for giving me a chance to speak with you for the next couple of minutes on the imaging pitfalls in the evaluation of juvenile spinal arthritis with a focus on axial disease. Over the next couple of minutes, we'll be focusing on two specific objectives. One, to learn the age-related changes that make axial disease imaging challenging in youth. And two, to discuss a few age-specific mimics of axial inflammation in youth. So a question that I get all the time at meetings and also in clinic is spondyloarthritis really a problem in kids? And my answer is always yes, it really is. So we know that up to 20% of adults with ankylosing spondylitis have symptom onset prior to age 18. We also know that spondyloarthritis accounts for up to 20% of juvenile arthritis. Treatment for this disease is often suboptimal, and less than 20% of children and adolescents with spondyloarthritis achieve remission within 5 years of diagnosis. And of course, because it's pediatrics, we have fewer drugs available for treatment than are available for adults with the same condition. When we focus on just axial disease, again, as I told you on the last slide, up to 20% of adults with ankylosing spondylitis actually have disease onset before age 18. And we know of those kids with juvenile spondyloarthritis, up to 20% of them develop sacroiliitis within several years of diagnosis. In comparison to adults with spondyloarthritis, back pain and stiffness are relatively uncommon in kids. And I'm showing you the data from an older but very important study below. And as you can see here, the major differences between juvenile onset and adult onset spondyloarthritis are that back pain is much less common in children. Root joint or joint arthritis like hips is more common in children. And peripheral arthritis is a much more frequent manifestation in children than it is in adults. So the question then becomes, when do we start to worry about sacroiliitis? Should we look for it at diagnosis? Well, we set out to answer this question and evaluated 40 unselected children, meaning consecutive children were approached with a new diagnosis of spondyloarthritis, regardless of whether or not they had any complaints of back pain. And these children that were enrolled had a diagnosis of SPA within the last 6 months. And all of these children underwent MRI. And what we found were that 8 of 40 children, or 20% of our cases, had evidence of sacroiliitis within the first 6 months of disease. On the top table, I'm showing the difference between the groups in a handful of clinical metrics that we collected. And as you can see by the p-values, there really weren't any significant differences between the two groups. We also collected some serologies, including HLA-B27 and inflammatory markers. And using these tests, I show you in the table on the bottom, we were able to show the predictive probability of kids having sacroiliitis. And as you can see, if children were HLA-B27 negative and had a normal CRP, the likelihood of having sacroiliitis was pretty darn low at 0.01. However, if the CRP was elevated and the HLA-B27 was positive, that predicted probability went up to 0.84. So this study showed us that, one, we needed to be concerned about sacroiliitis at disease onset, again, affecting 20% of kids. We found that 50% of the children had bilateral disease. What was really scary was a good majority of the children with inflammation also had evidence of damage. And what was really tricky was that of the 8 children who had sacroiliitis on imaging, only 3 of them actually complained of back pain. So that's where the predictive probability actually comes into play and may help you figure out who really should be screened. So now that I told you we need to look for sacroiliitis, how good are we actually right now in terms of identifying it? So this is a study in which 8 hospitals across the US each contributed up to 20 cases of consecutively imaged children and adolescents with juvenile arthritis and suspected sacroiliitis. Each of the MRI studies were reviewed by a panel of 3 experienced pediatric radiologists. And the test properties of the local reports were calculated using the Central Imaging Team's assessment as the reference standard. So as you can see on this table, the sensitivity of the local reports for active sacroiliitis on MRI was actually quite high and varied from 80 to 100% across sites with an overall sensitivity of 93.5%. So this was really good, meaning very few cases of sacroiliitis were missed. However, the positive predictive value of the local reports ranged very widely from 12.5% to 100% with an overall positive predictive value of only 52%, meaning there were a lot of false positives. So why all these false positives? Well, it turns out that normal maturational changes are pretty tricky. And if you're not used to looking at adolescent studies, some of the normal maturational changes can actually be confused for inflammation. As shown by the yellow arrows here, maturational changes consist of bright apophyseal cartilage. And this is an imaging from an 11-year-old healthy boy. So in one study, we actually aimed to quantify the maturational changes over time. So we used images prospectively collected on 70 healthy children ages 8 to 18 years. My colleague, Nancy Chauvin, developed an ordinal system that grades the amount of subchondral signal in the maturing skeleton from 1 to 4, shown here on this slide. And the take-home points from this study were that children progress from type 1 to 4 as they approach adulthood. The metaphysio equivalent signal in healthy children is typically homogeneous, symmetric, and primarily on the sacrum. So on the left, I'm showing you a key example of this. So type 1 change is characterized by homogeneous bright subchondral signal extending along the sacral apophyses. Types 1 and 2 signal were present in most prepubertal children. And type 4, which is present in the kids who are almost adults, is essentially equivalent to the normal imaging that we see in adults. And we think that this metaphysio equivalent signal change is really conversion of the physiologic red marrow along the articular surfaces with advancing age. But you can see how people who aren't used to looking at adolescent images might see that apophyseal signal as inflammation and wrongly conclude that the patient has inflammatory sacroiliitis. So you really need to be careful. This is another way of showing the same data. So again, on the left, what you can see is that the prepubertal children predominantly have type 1 and type 2 signal. And by the time the children approach skeletal maturity, there is no detectable type 1 signal, and type 2 signal is present in less than 10%. So MRI can also be tricky in youth for other reasons. So as part of the same prospective study of 70 healthy kids, the prevalence of cortical irregularities was also evaluated. And it turns out that sacroiliac joint cortical irregularities are pretty common. But there's some patterns that we can all recognize. So the cortical irregularities occur most often along the ilium and are most numerous, again, in that peripubertal group. And these findings correlate with prior autopsy findings, which report that the sacroiliac bony surfaces are smooth right up until puberty, and thereafter develop bony ridges and grooves, primarily on the ilium. Now, cortical irregularities, as many of you know, can also be seen in adults, but in that population, irregularities sometimes infer degenerative change, which we obviously would not expect to see in our younger population. So it's just important to recognize these features as variation in normal anatomy so that, that they're not mistaken for erosions, prompting our patients to unnecessarily be put on medications. And here I'm showing you an arrow to two of these cortical irregularities, which again, to many of us would look like erosion. So now I want to move on to describe some age-specific mimics that you should keep in mind. So our first case is a 9-year-old female who presented with acute onset left hip and buttock pain for 1 week. She described the pain in the left hip and lateral thigh and buttock as throbbing and constant. She had been hit by a soccer ball before the pain had started, but had no visible bruising to indicate that it was a severe injury. She had minimal response to ibuprofen. She had no other joint complaints and had a fairly unremarkable past medical history. On serologic evaluation, she had normal or negative CBC, CMP, rheumatoid factor, and HLA-B27. Pertinent abnormal serologies were that she had a lot of inflammation. Both her CRP and ESR were elevated, and the ESR was actually elevated to a greater extent than the CRP. On imaging, her X-ray of the pelvis was unremarkable. So now I'm showing you the MRI that was done on this young patient. So on the left STIR imaging, you can see bone marrow edema on both sides of the left SIJ, a fairly sizable joint effusion, and you also see edema in the gluteus musculature, which is uplifting the iliac muscle. On the image on the right, we see multiple prominent bilateral inguinal nodes, which you really would not expect to see in inflammatory sacroiliitis from JSpA. So what did this patient ultimately have? Serologies came back consistent with Bartonella or cat scratch infection, which again, maybe not highest on your differential because this patient came in complaining of injury after soccer. But on further questioning, after this imaging was obtained, the patient actually said that she had played with a kitten at the neighbor's house on numerous occasions. So what do we know about Bartonella and sacroiliitis? We know that 10% of Bartonella infections result in MSK manifestations, and these can vary. They include myalgia, arthritis, arthralgia, and less commonly, tendinitis, osteomyelitis, and neuralgia. In terms of which joints are most frequently affected, it's mostly knee, ankle, wrist, hand, and elbows. So sacroiliitis is not at the top of that, but certainly something that you need to keep in mind, especially with atypical features that don't really fit with inflammatory sacroiliitis. And in this case, I would say is the acute onset, lack of response to ibuprofen. You have imaging findings showing inflammation in adjacent musculature as well as prominent lymph nodes. The second age-related case is a 16-year-old male presenting with arthralgia, myalgia, and acne. And so this is a 16-year-old severe acne on the face and upper back. And 1 month after starting retinoic acid, developed pain in the lower extremities, gluteal region, and lower back. And he reported when he came to see the rheumatologist that this pain had been present for at least 2 months at this point. Was a little bit responsive to NSAIDs. On family history, there was a paternal aunt who had inflammatory bowel disease. On physical exam, he had some tenderness with direct palpation in the sacroiliac joint and along the posterior iliac crest. And on laboratory evaluation, he had a normal or negative HLA-B27, CBC, CMP, and ESR, and pertinent abnormal serologies were that the CRP was slightly elevated. So what did we see on imaging? So on T1, which is the image on the left, the findings are actually looking fairly normal. On STIRT imaging on the right, we see bilateral sacral subchondral edema, consistent with sacroiliitis. So what do we know about sacroiliitis and retinoic acid? We know that there's an association with cumulative dose of medication and lower back pain, and in some cases, obviously, sacroiliitis. In one small case series, sacroiliitis that was seen after initiation of retinoic acid was bilateral in the vast majority of cases. And we also know that if the retinoic acid is stopped, the symptoms associated with sacroiliitis and the imaging findings resolved fairly quickly. But by fairly quickly, I mean a couple of weeks. So in summary, axial disease affects 20% of juvenile SPA patients and is a major problem. MRI of the pelvis is a key part of the assessment of sacroiliitis in youth. The sacroiliac joint in maturing children and adolescents looks different than in adults, and you need to become familiar with this, as do your radiologists. Age-related changes make axial disease challenging. In particular, the subchondral edema that's seen as normal maturation and quarter irregularities. And mimics of sacroiliitis to consider, specifically in youth and the adolescent population, that you may not consider in your adult patients are cat scratch disease and retinoic acid-induced sacroiliitis. So with that, I want to say thank you. I have a lot of collaborators who have contributed to the research that I'm presenting to you today that are all listed here, as well as some very generous funders. And I look forward to taking your questions.
Hi, I am Matthew Stoll. I am a pediatric rheumatologist at the University of Alabama at Birmingham, and my topic is the treatment and outcome of juvenile spondyloarthritis. I will begin with treatment. And here are my learning objectives. There are two prospective studies in psoriatic juvenile idiopathic arthritis. The first was the CLIPPER etanercept open label study, and the second one was the Junipero randomized controlled study of secukinumab in both enthesitis-related arthritis and psoriatic arthritis. The CLIPPER study was an open-label study of children with extended oligoarticular JIA, psoriatic JIA, and ERA who were treated with etanercept. The spondyloarthritis patients were aged 12 to 17 at baseline with a mean disease duration of less than 2 years. The initial outcome assessment was performed at 12 weeks, with long-term follow-up most recently published for 6 years. And here's the entirety of the data up to 6 years. You can see that they responded quickly. All three groups did, about more or less equally, and they maintained this response for 6 years. The other study that included children with psoriatic arthritis was the Junipero study of secukinumab and JSpA. This was a withdrawal phase study of secukinumab in 97 children with ERA or psoriatic arthritis. 86 of them received at least one dose. The mean age of the participants was 13.7 years for the ERA group and 12.2 years for the psoriatic arthritis group. All 86 patients received secukinumab open label for up to 12 weeks. The responders were randomized to secukinumab versus placebo for up to 100 weeks, and the primary endpoint of this study was time to flare. So this is the open label phase where all children received secukinumab, and what this shows is on the y-axis, the outcome is the J-27, which is an outcome measure used in pediatric rheumatology and juvenile arthritis that includes the active joint count, the patient global, and the MD global. And you can see that both groups responded well in this time period. So then the responders were randomized to continue on secukinumab or to be treated with placebo for up to 100 weeks. Any child who flared while on placebo was then assigned to study drug open label. And what this shows is that the y-axis is the proportion of patients who flared during this period of time, and the x-axis is days. And what this shows is that over time, the children who received the placebo were more likely to flare compared to those who were maintained on the study drug, with a hazard ratio of 0.28. So that is it for prospective studies in psoriatic arthritis. There are 5 prospective studies in enthesitis-related arthritis. These are summarized on this table, and I will go through them one by one. So we're all interested, I know, to hear about sulfasalazine. So both groups, this is a randomized trial that was completed in 2002. Both groups, the placebo and the treatment arm, demonstrated improvements in active joint count, enthesitis count, and the pain visual analog scale, but there were not differences between the two groups. The only significant improvements were seen in the patient and MD global, that's shown in the table below, where the sulfasalazine group were more likely to have overall improvement in both outcome measures as compared to those who received placebo. Next is adalimumab. This is a randomized trial where the outcome assessment was performed at 12 weeks. And the outcome in this case was the active joint count. And what's shown here is that the patients who received study drug had a lower active joint count or a greater change in active joint count compared to those who received placebo at the endpoint of 12 weeks. And then they did converge over 52 weeks when the placebo arm received the study drug open label. This is a etanercept study. This was also a withdrawal phase study for the first 24 weeks. All children received etanercept open label. And you can see here, this table summarizes that overall the children improved with etanercept. And then the responders were assigned to either etanercept or placebo in a randomized fashion. And the output in was time to flare. And what you can see is that the children who were maintained on etanercept were less likely to flare with a p-value of 0.021 as compared to those who received placebo during this time. The infliximab study was completed in 2007, but has not yet been published. I am hopeful that we will see some data in the not too distant future. There were 2 treatment arms, infliximab versus placebo. Only 26 subjects were enrolled, and the information about the study is available online at clinicaltrials.gov, and the link is shown here. The primary outcome is at week 12 with an open label extension up to week 52. With fairly limited data, prospective data on the treatment of spondyloarthritis in children, the question emerges, can we extrapolate from adult studies? And I would argue that we can if there is sufficient safety data of the drug in children, and from an effectiveness standpoint, whether the disease process is similar in adult versus the pediatric subjects. First, I'll begin with safety, and there are 2 important safety events that we review with our patients, infections and malignancies. So for infections, I'm comparing registry data in patients with juvenile arthritis who've been treated with TNF inhibitors and patients with rheumatoid arthritis who've also been treated with TNF inhibitors. And the BICR study is in children with JIA. The BSRBR registry is in adults with rheumatoid arthritis. And what this shows here is that serious infections, and both of them use similar definitions for what constitutes a serious infection, were somewhat higher in the adult patients as compared to the children. And this is likely because adults are more likely to have comorbidities that are going to put you at higher risk of infections. However, the important point is that bottom line here is that our patients with JAA generally tolerate these medications from an infection standpoint. With respect to malignancies, Timothy Buchman studied this issue in 2018. He looked at 90,000 children with either inflammatory bowel disease, psoriasis, or juvenile idiopathic arthritis. Of these, about 15,000 were treated with TNF inhibitors, the rest were not. What he found is that the incidence of malignancies was slightly higher among those who received TNF inhibitors compared to those who did not, and that held whether you looked at all malignancies or specifically if you looked at those as lymphoma. However, this difference was not statistically significant. Additionally, he argued that some of this difference could have been due to confounding by indication. Overall, I would say this data is highly reassuring that while there may be a higher incidence of malignancies among those receiving TNF inhibitors, the overall risk of cancer among children, whether or not they are on TNF inhibitors, is very low. So now we can speak to effectiveness, and the question then is, are the disease mechanisms in spondyloarthritis and ERA and psoriatic arthritis similar to those in adults? For ERA, I would argue that the answer is yes, that the spondyloarthritis in childhood is very similar to its counterpart in adults based upon demographics, joint distribution, the presence of intestinal inflammation, and genetics. What about psoriatic arthritis? So here it's slightly more complicated. There have been several studies over the years showing that children with psoriatic arthritis have a bimodal age of onset distribution, where there's a peak in early childhood around age 2 or 3, then a second peak in mid to late adolescence. So we and others have compared the clinical features of late onset versus early onset psoriatic arthritis. And what we found is that only the late onset group resembles spondyloarthritis in adults. The early onset children are more likely to be female, to have small joint disease, a positive ANA, and to have chronic silent uveitis, whereas late onset children are more likely to be male. They have more enthesitis, frank psoriasis, oligoarthritis, axial disease, HLA-B27 positivity, and overweight obesity. Because of that, I would argue that we can extrapolate from a treatment in adult studies for the late onset psoriatic arthritis group, but perhaps not for early onset. So my approach to early onset psoriatic arthritis is, in the absence of data to the contrary, and given questions as to whether or not early onset psoriatic arthritis even resembles spondyloarthritis, it seems reasonable to treat early onset psoriatic arthritis similarly as we do oligo and polyarticular JAA. And to that, I would refer to the 2019 guidelines that we published. Specifically, methotrexate is recommended as first-line therapy. TNF inhibitors are recommended for patients with inadequate response to methotrexate without any preference among individual TNF inhibitors. If there's no response to an initial TNF inhibitor, we recommend switching to a different mechanism of action. Specifically, the guidelines spoke to abatacept and tocilizumab. Tofacitinib was not mentioned in these guidelines, although it now has indication for JIA. An important point here is that both abatacept and tocilizumab are not widely used for psoriatic arthritis in general. What about late onset psoriatic arthritis or enthesitis-related arthritis? Here, I will speak to some recommendations that were published in 2015 by the GRAPPA group, and that will be updated shortly. And they speak to domains of psoriatic arthritis which drive treatment. And their primary domains were listed here: enthesitis, peripheral and axial arthritis, dactylitis, nail disease, and psoriasis. Of special mention, which I believe in children would be considered of primary importance, are uveitis and inflammatory bowel disease. Why is this concept important? Because disease features do not respond equally well to therapies. Therapeutics that are highly effective in one domain may have no effect or even worsen a second. So this is summarized over here. The domains I am highlighting in this slide are inflammatory bowel disease, peripheral spondyloarthritis, axial spondyloarthritis, psoriasis, and uveitis. So NSAIDs may be effective for peripheral and certainly for axial spondyloarthritis, not for the other domains. Traditional DMARDs are not a benefit for axial spondyloarthritis. The soluble TNF receptor, etanercept, works for arthritis and psoriasis, but not as well for the complications, including IBD and uveitis. The same is true for IL-17 inhibition. The TNF monoclonal antibodies work across the board here. Anti-L12-23 or anti-L23 works for IBD, peripheral spondyloarthritis, and psoriasis, but not for axial spondyloarthritis, and has not been well studied in uveitis. The JAK inhibitors work for most of these domains, but their usefulness in uveitis remains uncertain. T-cell co-stimulation inhibitors work for peripheral spondyloarthritis and possibly for uveitis, and the PDE4 inhibitors likewise work for peripheral spondyloarthritis and psoriasis, but not the other domains. So to summarize, TNF inhibitors and secukinumab are effective in psoriatic juvenile arthritis and enthesitis-related arthritis. With the exception of early onset psoriatic arthritis, we can extrapolate from the adult data for PSA and ERA, in which we focus on key domains such as psoriasis, uveitis, IBD, and axial spondyloarthritis. What about the outcome of juvenile spondyloarthritis? I will begin with the good news. Overall, in the last 2 or 3 decades, we are using more biologics in JIA as a whole, and we're seeing better outcomes. This study looked at articular and extra-articular damage. An example of extra-articular damage was uveitis and consequences thereof, and both have decreased over time over the last 2 to 3 decades overall in children with arthritis. Now the bad news. Spondyloarthritis is lagging behind. This study from Norway evaluated long-term data from 55 patients with ERA matched to 55 patients with oligo or polyarticular JIA. They looked at the health status after a median of 15 years. DMARD use was fairly infrequent in both groups, although more common in the ERA patients. Despite that, those with ERA had more disability, lower physical function scores, and more body pain. Similar trends were reported in psoriatic arthritis by the same group. This was after both 15 and 23 years from diagnosis. Again, the patients with PSJIA were more likely to use DMARDs and prednisone, but despite that, they had worse function and more pain. At a single center, Tim Buchelman looked at 88 children with JIA who had been treated with a TNF inhibitor. Of those, the majority had a form of spondyloarthritis. What he found is that the patients with ERA were less likely to have obtained remission compared to those with oligo or polyarticular JIA. In addition, he reported that baseline enthesitis negatively predicted remission status, which was seen in only 25% of those with enthesitis versus nearly half of those without. Likewise, Pam Weiss looked at pain intensity and health status from the CARA database. She was able to evaluate over 2,500 patients with JIA, of whom about 400 had spondyloarthritis. And what she found is that ERA patients reported highest pain intensity and highest pain frequency, even after adjusting for medication use and other factors. This was also seen in a Canadian study. This included 916 patients with JIA, of whom about 150 had spondyloarthritis. Their outcome was inactive disease within 1 year among those who were not receiving early biologics or triple therapy. And what they found was that having ERA or seropositive polyarticular JIA were associated with reduced likelihood of remission. Dax Rumsey also reported that among children with JIA as a whole, whether or not they had ERA, having enthesitis at baseline was associated with worse patient-reported outcomes after 5 years. To summarize the outcome data, temporal trends show better outcomes over time for all categories of children with JIA. However, Children with ERA and possibly psoriatic arthritis are at greater risk for poor functional outcome and pain, despite similar patterns of advanced medication use. And that implies that we need improved targets for enthesitis. Thank you.
Now we'll proceed with post-test questions. First question, which of the following conditions is not typically considered in the juvenile spondyloarthritis family of related diseases? Answer choices: A, enthesitis-related arthritis, B, juvenile psoriatic arthritis, C, juvenile ankylosing spondylitis, D, chronic recurrent multifocal osteomyelitis, and E, systemic juvenile idiopathic arthritis. Please answer now. The results is systemic juvenile idiopathic arthritis. Question 2. Which of the following can be challenging to interpret on the pelvic MRI in skeletally immature patients? Choose all that apply. Answer choices: A, bone marrow edema, B, fat metaplasia, C, erosion, D, capsulitis. Please answer now. And the correct responses are bone marrow edema and erosion. Now, the last question. Which of the following statements is correct? Answer choices: compared to adults, children are at higher risk of developing serious infections following exposure to TNF inhibitors. IL-17 inhibition with agents such as brodalumab or secukinumab is generally contraindicated in children with inflammatory bowel disease. Baseline enthesitis is a predictor of improved functional outcomes in children with JIA. And D, children with ERA are more likely compared to children with other categories of JIA to enter remission following exposure to TNF inhibition. Please answer now. And the correct response is IL-17 inhibition with agents such as brodalumab or secukinumab is generally contraindicated in children with inflammatory bowel disease. And now we'll move on to panel discussion. First of all, I would like to welcome all our panelists. Thank you all so much for such great presentations. While we await for audience to pose their questions, I'm going to start off with some questions of my own. My first question is to Dr. Rumsey. You mentioned about the challenges with the classification system of JSpA. Can you tell us how this has impacted patient care in your own experience?
This is a good question. I think sometimes it's hard to classify these patients, and then if you follow the EILAR criteria very specifically, sometimes they end up with this undifferentiated category. So in terms of how it's impacted care, I guess it's kind of not a very satisfying label, first of all, for the patients and families to have as undifferentiated. Sometimes it can impact the kind of approvals of medications if we can't call them by a certain name. That might be some ways. But this is being worked on, and it's recognized that this is an issue. And in the new classification criteria, people are trying to address this. So good question. Thanks.
Thank you so much. Looks like the audience is still shy. I'll proceed with my next question. This question is for Dr. Wise. Can you please speak to the role of IV contrast in MRI of sacroiliac joints?
Sure. That's a great question, and I think it's one that lots of pediatric providers have across the country because practice is still relatively not standard. The adult practitioners for quite a while now have not been using IV contrast, particularly when the imaging is done for the primary purpose of determining whether there's inflammatory disease at the SIJs. And studies have been done in adults to show that while contrast adds the benefit of being able to see the actual joint lining and or fluid better than non-contrast studies, in terms of determination of sacroiliitis being there or not, it actually does not add any incremental value. A couple of years ago, ago, there were 2 studies that actually showed something very similar in the pediatrics realm, again showing that the addition of contrast really didn't enhance our ability to detect sacroiliitis or not. And that's a big deal for kids because most normal kids really don't like being poked with an IV, especially if they don't, it doesn't need to be done to enhance the evaluation of the imaging. The additional sequences that are required for contrast add a lot of extra cost and time in the MRI scanner, which can also be a big deal for kids too. So in general, at least at my institution, when we're imaging primarily for inflammatory sacroiliitis, we do not use contrast.
Thank you so much. That was a great information. My next question is for Dr. Stoll. You showed data about how baseline enthesitis is a poor predictor for disease remission. Do you have any hypothesis as to why that might be?
I think the enthesitis is difficult to treat. Just anecdotally, experientially, I've found that often it can be unsatisfying, and there may also be a lot of overlap between more central pains and peripheral enthesitis. That might be part of it as well. The data was actually Dr. Rumsey's that I used for this talk, so maybe he may have some insight into this as well.
No, yeah, I agree with what you're saying. There's a lot of overlap with central sensitization syndrome, so sometimes it's difficult to diagnose enthesitis, and sometimes there's like comorbid pain syndrome, so that's part of the issue too. And it's often not imaged, so I mean, with imaging, sometimes it's easier to tell if there's true enthesitis, but it's not often done. It's often impractical.
Thank you both. My next question is for Asad and Amina. In your experience, what were the most important factors for you in choosing a particular treatment regimen for Asad? And what information do you think would be important for clinicians to share with their patients when discussing different treatment options?
So, well, I think for me, the first anti-TNF agent I was put on worked perfectly, and it has worked ever since. I've been lucky enough that the pain has not ever flared back or the anti-TNF agent has stopped working. So we've never really had to change the treatment. I've also taken methotrexate once a week. And so for me, I never had to change the treatment, but I think for like other people who also have spondyloarthritis, they probably have had to change, try out different treatments to see which works the best for them. So.
And just to add to that, when we were through Russ's journey, it was initially quite overwhelming. However, when we discussed with our physician, just the treatment options, research, just understanding more of the disease and treatment, just getting a good education background in terms of what has worked, what has not worked, we felt a lot more comfortable going forward, just getting more education on the subject. So that just helped us feel more in control and more empowered going forward with his treatment.
Thank you both for sharing that with us. My next question is for Dr. Wise. Can you please share with us any new research being done to identify axial disease more readily in children?
Well, that's a great question, and one I did not anticipate. There's some work. I can't speak to unpublished studies that other folks are doing, but there's some work that my group is doing to look at different imaging techniques to enhance our ability to differentiate between those tricky maturational changes that can fool all of us, to see if there's a more fail-proof way that less experienced radiologists can look at and be able to tell more easily whether there's pathology there or not. And some of those imaging techniques include T2 weighted imaging and diffusion weighted imaging.
Great, thank you. My next question is to Dr. Stoll. Can you please share a little bit more about role of methotrexate, or rather lack of role of methotrexate in spondyloarthritis?
So it's interesting that today I spoke to the 2015 GRAPPA guidelines, but just today the revised 2021 guidelines were just published. And they spoke to that. They said there's conditional recommendations for it in peripheral, and this is on PSA. There's conditional recommendations for PSA, for enthesitis, although they do recommend, if you're able to consider first-line treatment with a biologic. Having said that, I think methotrexate does have some value in peripheral spondyloarthritis. There's not very much data. I think most of the interest and most of the data for peripheral SPA, at least in enthesitis-related arthritis or undifferentiated SPA in adults, is with sulfasalazine. I do believe that methotrexate works. I've seen it work for peripheral. Again, for axial disease, I think the data are pretty clear that traditional DMARDs, they may reduce morning stiffness, especially in the case of sulfasalazine, but traditional DMARDs are not all that effective.
Thank you all so much. You gave such a great presentation, and this has been a very enriching discussion. I would like to invite the panelists to convey any parting message or take-home points to the audience. I'm going to first invite Asad and Amina.
Well, so a parting message. Okay, well, I think that definitely just in general, just like the rheumatologists have definitely changed my life. Basically, when I first was diagnosed, it seemed very like overwhelming, and it's like, well, am I gonna have to live with this for the rest of my life? And basically, thanks to the rheumatologist, we've been able to find a treatment that works for me, and hopefully all the other doctors and rheumatologists in the world will continue doing research so we can help everyone else who's in need, just like I used to be. And yeah, so just thank you to everyone.
Just to add to that, yeah, just like Asad said, thank you so much. It's with all the treatment and guidance and support that we have come this way, and we feel a lot more empowered in Asad's journey. And of course, no one can, everyone's journey is different, but as long as we follow our treatment plan, we feel in a much better space, and we hope others can benefit from, our stories.
Thank you. Dr. Ramsey?
Yes, thank you very much for everyone who attended. I think that a takeaway point would be it's important that doctors think of this diagnosis and try to think of it as a possibility, because the earlier that we see these patients, the earlier they get treatment, the better they do. So if you see any patients with like what sounds like inflammatory back pain, or like what seems to be enthesitis, like heel pain or pain around the knees, things like that, or if they have psoriasis or a family history of any of these conditions, it's important to try to get them referred as soon as possible so we can get them on early treatment. But that's my take on it. Thanks.
Thank you. Dr. Wise?
I'll keep my parting message focused on imaging, since that was what my talk was on. But in terms of, when and if you have suspicion for axial disease, imaging plays such an important role, because there's so many different things that can cause pain in the low back that can be misdiagnosed as spondyloarthritis too. And I think we really want to do our due diligence and treat the kids with the best treatment possible to get them back into their normal activities. And if that means starting a biologic because they have inflammatory disease, then we should do it. But if it's from a medication that they're taking for their acne, then we need to get them off of that and feeling better. And if it's from central pain and not from sacroiliitis, then we need to get them into physical therapy and counseling to help them. So I think there's a big differential, and a lot of the recent work has really shown that imaging is really the best thing that we have to differentiate those. The second major message is it's really important to work with imaging experts that are used to looking at imaging in children, because the low back in kids, especially in the peripubertal era, looks so different than adults. And it's so helpful to have somebody who's used to looking at those normal maturational changes.
Thank you. And finally, Dr. Stoll.
All right. Well, thank you all very much for organizing this. So my parting message is that until about 10 years ago, it didn't really matter a whole lot what you called it, except for maybe epidemiologic purposes. But now that we have so many targeted therapies, that really matters how we identify it. And if you identify some pits on the fingernails or recognized dactylitis, and you call it psoriatic, that's going to open up a whole bunch of pathways, treatment pathways, including some that are recently approved in children that you might not otherwise consider for other varieties of arthritis. And what we call in children often influences what the adults diagnose them with when they inherit these patients. So it's really important to be thoughtful when we make these diagnoses.
Thank you all so much. Now we have some last announcements before we conclude this webinar. So if you liked today's webinar, please check out patient and clinician podcasts related to the same topic that have now been released and are available at the link provided. They can also be accessed through the National Psoriasis Foundation website. And also, please stay tuned for future seminars. Next slide, please. With these topics that are going to be released over the upcoming months. Next slide. This program is accredited for 1.5 AMA PRA Category 1 credits. To earn CME for this program, you must complete the evaluation. You may do so in a few ways. Shortly, the evaluation will fly over the screen so that you can complete it right now. That's the easiest way to do it. You may also access the evaluation by clicking the direct link in the slide deck, clicking the link in the menu, or scanning the QR code. If you're not able to complete the evaluation now, the link will also be sent to you in a post-event email. And once you've completed your evaluation, a CME certificate will be mailed to you within a week. Next slide. Thank you all once again for attending the seminar. Thank you again for all the panelists for such an enriching discussion. Thanks to the patients and families for sharing your journey with juvenile spondyloarthritis with us today. Thanks to the audience for your participation. We would also like to thank SPARTAN, GRAPPA, SAA, and NPF for putting together this seminar series. Finally, thanks to Pfizer, without whose educational grant, this program would not have been possible.